We, on this first panel, are going to take a few steps back because he very eloquently, and you by asking him questions, laid out the problems with where we are today. But what we're going to try to do on this panel is set out a vision for what primary care should look like in the future. Because if you don't know where you're trying to get, it's very difficult to get there. Now, you have full bios of my wonderful panelists in the brochures on your chair, so please refer to them. I will give them the briefest of introductions as I ask them questions. And so I'll start out with you, Atul.
Okay.
So Dr. Atul Grover with the American Association of Medical Colleges. So from your perspective, what have you seen in primary care that would help you construct a vision for what it should look like in the future?
You know, I think part of this, like most policy issues, is what's the problem you're trying to solve, right? And I think Senator Whitehouse raised a couple of different issues, one of which was, well, we have this low life expectancy. We just published something in the last couple of months to demonstrate that, you know, if you want to have the life expectancy at birth of Germany, if you just reduce deaths from gun violence, alcohol, substance use disorders, you'd pretty much be Germany, right? And Germany is a good example because they're a heterogeneous society that looks like us. So, you know, we certainly don't do as well with metabolic disorders, but the question is that the primary care doctor, the primary care nurse, nutritionist, public health social worker, right? We talked about the social worker, the air conditioner, the TV. There are other issues that we need to invest in as well. When we look at the people providing primary care, we've often sort of relied on international comparisons to say, well, there's more primary care doctors relative to specialists in other countries. Our colleague from Europe certainly seen that. One thing that we have that other nations don't for the most part is a lot of advanced practice providers that are not all doing primary care, but many are. So if you look at groups like nurse practitioners or physician assistants, about 70% of nurse practitioners are currently practicing primary care. That's less as the new graduates come out. But it ends up going from about 300,000 FTE docs providing primary care, right? So one for about every 1,100 people, up to about 500,000. And all of a sudden then, we look like the Netherlands, right? We do really, really well in terms of counting bodies. So the bodies themselves are not, I think, the core issue here. What we do need to get at is how do you get those people out there who are qualified to do primary care to provide the services that you want people to get in the places that you need them. And in some cases, that may be that you really need to have a general internist or a family doc or a pediatrician. In other cases, you may be fine with others. And in fact, Austin Fracht and colleagues did a paper a couple of years ago showing that for about 25% of ambulatory visits, the care was actually being provided by advanced practice providers. So about 25% to 40% of visits for things like lower back pain, respiratory infections, UTIs, hypertension were being provided by these other folks. And that's without even counting people like social workers or pharmacists, right, who could also be doing more. And I think in the last 10 years, if we look at the growth in just people qualified to train, who are trained in primary care, family docs, general internists, again, they can choose to subspecialize, they could do Botox, they could do lifestyle. That's a different issue. But in terms of the actual bodies, between 2015 and 2025, we saw that the number of family medicine first-year trainees increased by about 2,000. Number of general internal medicine trainees increased by about 2,000. But if you look at ortho, neurosurgery, radiology, they increased by about 100, right? So now we've kind of pivoted to this other side, and we're really starting to see challenges just with the bodies out there in meeting subspecialty care needs. And so we really need to think about what is it that we're after here? How do we get to that goal, and how much of it is really the bodies versus other stuff in the ecosystem?
Okay. So Atul, you're saying we really have enough people in primary care. It's maybe how we're using them. So Dr. Yalda Jabbarpour, as a family physician and researcher, what have you seen change in primary care over the past decade, and how does it help you think about what we need in the future?
It's a great question. So I think, what Atul's talking about, which is easier to find in the data, is, the actual bodies. What's harder to find in the data is what those bodies are doing. So physicians are trained differently than nurse practitioners, are trained differently than social workers, are trained differently than pharmacists. And so we can't make one-to-one comparisons in the way that the data allows us to do. The second thing that we've noticed, at least in our data in family medicine, is that if you just look at physicians, the numbers might be a certain way, but very few of those physicians are working full-time anymore. We are choosing other careers, other outlets for our time in order to remain in primary care. And why are we doing that? Because the setting is not set up to support primary care physicians. It is very hard to work 5 days a week clinically with not much support without burning out. And that's a huge problem. So I think the numbers tell one story, but what's really happening in practice in terms of what we're providing, how often we're providing it, tells another story. The other thing is our patients have become more complex, so much more complex. I've only been practicing since 2008, so I feel like I'm young, but you know, it's a long time, and I have seen such a change in that time in terms of the complexity of the patients, their medical complexity, their social complexity, their mental health needs. Primary care is the place people go for their mental health care. So each visit is becoming longer and more complex, even though we don't have the time to meet those needs. So I think we've seen those changes. I think Atul is right in that we need a team to take care of these patients. There's no way that physicians alone can do it. Whether we have a shortage, which I truly believe we do have a shortage if you count FTEs and what people are providing, whether we don't have a shortage, what we know is that patients are having a hard time getting in, they're not getting all their needs met, and clinicians are burning out. So we need that team around us.
So last but certainly not least, I'll turn to you, Dr. Eliana Perrin, our Hopkins Distinguished Professor of Primary Care. And can you talk about some of the things that you've seen going on related to your practice in Maryland that help you construct a vision for the future?
Yeah, no. So one of my professors when I was a resident said to me, the amazing Paul Wise, for those of you who know that name, said to me that pediatric care providers are the ultimate witnesses to failed social policy.
Absolutely.
We have failed social policy, and we are seeing that. We are seeing, as was already pointed out, a greater complexity. But the other thing that we're seeing is an erosion of trust. And that has made everybody in primary care's life harder. So what that erosion of trust means is that things that are probably some of the best things that I can possibly do in primary care, provide vaccines, not trusted. People want to do their own research. Do you know how much I'm paid to do research? So much. And yet people want to do their own research. Why do they want to do their own research? They don't trust me, us. And we have a system that doesn't trust us also. What Senator Whitehouse was talking about with prior authorization, that's a system that doesn't trust me. I wrote the prescription. That was my prior authorization. I suggested that a patient take this medication. I carefully considered why and why not, and I wrote that prescription. And now I have to, or someone that works with me has to spend a fair amount of time validating that, going through that, not trusting me, not trusting the patient to move forward. The last thing that's happened is an availability of knowledge to people that are not necessarily equipped to handle that knowledge. Example is that people want to see specialists before it's necessarily pragmatic to see a specialist. And they come with that impression because, again, they've done their own research, they want to do that, and so there's too few specialists out there for me to send people to. There's a lot of problems that I can handle on my own, and so that's another problem. I think that one of the ways that we reestablish trust is we bring people into our space that are trusted, Nurses are trusted. Community health workers are trusted. Social workers, for the most part, are trusted. The other thing we can do is go into the spaces that people occupy. Schools, neighborhood with neighborhood nursing. That's a great program that Dr. Zanton has started. These are programs that say, instead of you coming to us, because sometimes the walls of primary care can be way too high, we can come to you. And that is another way to establish trust. So.
Okay, so thank you for picking up there at the end on what we can do going forward. So establishing that vision for what primary care should look like in the future. Maybe I can loop back to you, Yalda, and say, when we were discussing this panel, you had found that there were some promising signs around use of AI and things like that. And when you talk about trust, can we bring those threads together? What are you seeing about the use of AI?
Yeah, and I'm a researcher, so I hate to use anecdotal evidence, but I do think there's evidence emerging about this as well. In my clinical space, we've started to use just the basics of AI with something called ambient listening. I think probably a lot of clinicians in the room are using this as well. And what this has done, I will say that it hasn't yet, I don't think, saved me time in clinic. I'm still leaving at the same time because this is emerging. But what it has done it has really reduced my mental burden so that I can take care of complex patients and not feel burned out at the end of the day. The fact that I can sit with a patient and talk like this and not have a computer screen in front of me is what I trained to do, what I went into medicine to do, to have that relationship. So to have this ambient AI to listen to us, to transcribe what I'm saying, and it's actually pretty good, takes away some of that cognitive load. At MedStar, we're looking at different ways to actually implement AI. So ambient AI is just a start. I think my patients are actually really liking it. I thought they might have some mistrust of the AI, but they tend to really like it. I understand that's probably regional. They like having the face-to-face. They like me coming out from the computer. The other things that we're looking at is AI to answer portal messages. I think portal messages are a huge burden for primary care. Patients don't love it because their primary care clinician is not getting back to them fast enough on the portal messaging, so they feel disappointed with that. So I think having AI with clinician oversight will be exciting. I think we're also working on ways to have that AI help us triage patients in a way. So there are systems out there right now where it will say, okay, the chief complaint for this patient is chest pain. I've gone into the room, I've used my ambient listening device. That ambient listening device knows the qualities of the chest pain. The AI is now looking through the patient's chart. When did they last have an EKG? When did they last meet with a cardiologist? When did they last have their lipid panel done? Are they a smoker? They're looking at guidelines that have been produced about taking care of patients with chest pain. They're bringing all that information together so that the clinician can just look in the chart and have a very succinct summary of their patient in order to make informed decisions for the patient. I think if we consider AI as part of the new healthcare team, I think it has a lot of advantages. The one thing I will say, I was around when we were implementing EHRs at MedStar, and there weren't enough primary care clinicians at the table during the choosing of the EHR system, the implementation and dissemination of that system, and now EHRs really don't work for us. Primary care clinicians really need to be at the table when there is development of AI, implementation of AI, choosing the AI system, and dissemination. So even though I don't necessarily have the time to be doing this, I'm trying to get as involved as I can, because lessons learned from the past. Every primary care clinician needs to be at the table while this is emerging.
Yeah. So Eliana, if I can come back to you, are you seeing this use of AI as well? And then how would you combine AI with the types of community-based teams, school-based programs, and things like that that you mentioned already?
Well, Yes, I am definitely seeing AI. I don't think it's as widely used in my space as it sounds like it is in yours. Anecdotally, again, the plural of anecdotes is not data, but anecdotally, I have heard that actually many primary care providers are saving lots of time. One person I know said that they've never seen the rush hour commute, and so now they're involved in the rush hour commute because they're actually getting home at a time that's a reality for them. I think we don't know a lot about how much the public does or does not trust AI. And I think when we're considering whether to invite this team member into our primary care space, we do need to know that. We ran a primary care symposium at Hopkins, and we actually had a session on AI, friend or foe. And I think there were elements of both expressed. But I think what isn't important is what I think of AI, or frankly, what you think of AI, but what our patients think of AI, what do our communities think of AI, and how can we, help them to understand it better, invite their thoughts about what role it should play. We are always making decisions for people who those decisions affect, and I think we need to learn more about that.
Atul, can you weigh in and also think about how this future vision might inform the way we need to be training people going forward?
Look, I think there's a lot of benefits to the current training structure, a lot of drawbacks, but one of the things that you do at a place like Hopkins is you have the ability to infuse not only the technology, but the other members of the team, right? Challenge is once you get out into the real world where you're on a fee-for-service system, where people aren't salaried, where it's potentially more capital investment or less revenue for you to invest in people or technology, then it becomes a real challenge. What I do think we can do, and one benefit is, whether it's getting out in time to be in rush hour or having less pajama time at night, is AI as a charting tool and a reference tool has been really helpful. Not necessarily something the patients are going to see up front, except more face-to-face time, less doctor in the screen time. But what I do think we need to do is to begin to lead, particularly as physicians, but others, to say, what are the pieces of work that it makes sense for us to do versus others? And what are the skill sets and training that those others might need as well? And how do we get consistency? And I'm curious on the nursing side, we see a lot of propagation of nurse practitioner programs where we don't necessarily know what the consistency is of a graduate. I know coming out of an ACGME program in peds or family medicine, what that person can do. Where we're not great as physicians is saying, okay, I can take some of this off of my table, not just in primary care, but in a lot of subspecialties. And we see that in our ortho clinics, a quarter of your care is going to be delivered by a PA or more, right? Your plain film of your lower extremity is going to be read by a PA who reads it better than I do as a general internist, right? And so can we decide up front as physicians where we need to offload some of that work to other members of the team? But I do think we have to address this issue. If the only thing that's left for an internist or a pediatrician or a family doc at the end of the day is incredibly complex patients who take an hour of intense work, can I really do that for 10 half days a week sustainably without getting burned out? I don't know.
So I think that's one of the cruxes of the question. So we've talked about how we have enough people, we might have to train them differently, we need to add AI as a team member, we need to make sure primary care is in multiple locations. But what about this critical issue of triage? Who needs to see what type of professional, even within the primary care sphere, and when? How do we create that future vision?
So one thing I'll comment, though, is when Senator Whitehouse talked about, well, we need, essentially, he was describing a gatekeeper. And before your time, but we remember the 1990s when everybody was going to be in an HMO. It was all going to be Kaiser Group Health.
Wait a minute here.
Right?
What just happened?
Okay. So when you're a full professor, right?
Okay,
so
fair. Thank you.
So when I graduated, we were all told, you will be an employee and you will be unemployable if you don't go into primary care. Well, it turns out Americans rejected that notion, right? So the idea that today we're going to go back to restricting choice when nobody trusts us or the institutions anyway, I think is very, very challenging.
So how do we make people want to enter the system through primary care? which I think all of us would want to if we felt like actually the primary care provider was going to be our quarterback, was going to help us navigate all of the systems, and would appropriately send us someplace where we could be seen more quickly or by someone who was better at reading our film than they were. That seems like a tall order.
I think we need to show the public what good primary care looks like. There are people out there who have had really good primary care, a continuity clinician that has been with them maybe since childhood, you know, if it's their family doc. But that is less and less common now. And the reason that it's less and less common is multifactorial, but it goes back to the fact that we are just not financially and otherwise supporting primary care the way that we are supporting other specialties. And when you have a system that's not being supported financially, you have practices that are overworked, under-resourced. You have trainees coming into these practices. Why are they going to choose primary care when they see this? So it's this self-fulfilling cycle. We can't support primary care. Therefore, we don't have a primary care system that's meeting the needs of the patients. Therefore, the patients are choosing to go to subspecialists instead of primary care, which means, again, we're not supporting primary care. So I think how we change that, I think as primary care, I've heard this said a lot in different circles, we need to do a better job with PR. We just really do. Our societies need to do a better job with this. Us as primary care clinicians need to do a better job with this. We need to be able to sell the benefit of primary care to the US population. I'm not a PR person, so I'm not going to be in charge of that. My role as a primary care researcher and physician is to provide good primary care in my office, but also to produce research that shows the benefits of good primary care. So we can all do our part, but I do think we have to just change the narrative.
I think the only thing I'll add to my colleagues' excellent points is the fact that, you know, even you use the word triage, which is an implication that someone's already sick.
True.
Or injured or unwell in some way. And I think one of the beauties of primary care, and this is especially true in pediatrics, but it's frankly true throughout primary care, is that I'm the person in charge of keeping well people well. And if I can spend more time with you when you're well, in seeing the real you, and seeing the little baby who's staying well, and getting to understand that family unit, that person in their community, you know, their jobs, their hobbies, their friends, their loved ones, all that makes them them when they're healthy and thriving, then I think that too builds trust. It also certainly builds whatever the opposite of burnout is. In me, it allows me to take joy in what I do. And so I think the height of primary care is prevention. And if we can prevent illness, prevent injury, prevent any lack of flourishing and thriving, then, you know, we are really living the epitome of primary care. And I think we're helping our patients, we're helping ourselves, and we're helping the bond that joins us.
I think the challenge there becomes cost, though, right? So if we use the highest paid professional in that setting to be the one to develop the relationship, do the reassurance, do the education, that becomes very, very expensive. And you end up looking more like a concierge practice where you can really only have a panel of 500 patients, and it's very expensive. But if you use community-forward nursing, if you have nurses, social workers, dietitians, nutritionists, others in your practice, can you figure out, but the triage issue is real. I'm not even sure if a fixed model HMO, closed network like Kaiser has actually figured out the best way to triage, right? And we certainly don't have a national system to tell people you're fine, or you go to your primary care doc and you can wait a week, or you go to urgent care, you go to the ER. Maybe AI can help us with that, but then the trust issue seeps back in. And again, these are investments. And if you look around you right now, we're not big on making investments in public health and infrastructure right now.
Well, we're leaving it to panel 2 to figure out how to implement our
Good.
vision.
Yeah, Dan will
so, so they're going to take care of that. We just have to set it for them. And so, we're getting the framework of it here. I've sort of repeated back some of the things you've said, but this issue of how do we have a system in which all the members of the primary care team, and we're now talking about a team, it's not just a primary care physician or a nurse practitioner, has that part of the job that brings them joy and allows them to get to know their patient, and yet still practices to the fullest extent they can to try and keep the patients healthy or help them when they're sick. And that's a challenge we're hoping technology will help us figure out. But it also maybe means that we need a different kind of professional who's able to sort of absorb that information, establish empathic relationships and things like that quickly. Do you think that needs to be part of training going forward? And if so, do we have any idea how to do that?
I guess you're looking at me on the training side. Again, I think the best thing that we can do is train by example. This is we have experiential learning. So the more we can create general internal medicine or family medicine pediatric clinics within our institutions that are doing the training, or putting our trainees out into well-qualified faculty members, community practices, I think setting that example is really key. But I also do think that, again, we need to, if you want to think about policy, figuring out why certain things didn't work, where the barriers were, is critically important. So why have we never gotten to per member per month, capitated, risk bearing? And there's a number of answers there that I think would have to be addressed before you could successfully sort of scale up those models. Otherwise, it's really, you're just going to reinforce people who have wealth, will go out and pay for concierge care. The folks that I did my primary care residency with that are in private practice, none of them have more than 500 or 600 patients in their panel now.
Mm-hmm. I want to, and this may be for panel 2 to solve, but I want to not cut off potential options for us. Everybody says concierge care is too expensive for our society. I don't know all the concierge folks, but I know from some examples that it's in the range of $2,000 to $3,000 per year per patient. If you think about it, that's actually not very much. We spend far more than that per person per year on care, and even primary care, we spend about $800 per person per year. So it's not worlds different. And so if we could get to a system that allows that payment structure, I actually think we'd see costs saved down the road, even with your most expensive
She's
example.
the CBO person. Ask her how we're going to score
Well, we're
that.
gonna ask panel
But
2.
there are many in the audience, so we can talk
Yeah.
at the break about that. Yes, moving
It would
money
be an
around in the
investment.
system probably needs to be on the table, and we need to invest more in people's health. I think we realize that. We have a lot of acute care that we didn't need to see, and because of lack of trust, sometimes people get more care than
But it
they
may
would
not
if
be
they
a
had it.
one-size-fits-all. Like when we spend a lot of time talking about medical homes, my 23-year-old does not need a medical home, right? I'm an old guy. I need a medical home now, right? So how can we selectively say, we're going to pay for this in the Medicare population, but for a lot of patients way before that, that's a really tough political conversation.
Well, and I think Yalda was commenting too, many people who are in the healthy parts of their lives are choosing things like convenient urgent care, after hours care, things like that, because it's not their top priority to have a relationship with a provider. Many people would argue that they don't want it until they need it, but that's what the choices people are making. So I'm going to remind the audience that on your chairs are pens and cards for you to ask questions. And my colleague Lauren will be coming around and collecting them from you. We'll make sure we get to them before the end of the panel. But we've done a good job of asking each other questions, but I wanted to explicitly give each of you the chance to ask one another a question. And I believe that we agreed we would start with you, Eliana, and you would pose a question to Atul.
So I don't think we've done a great job leaning into your expertise from an AAMC perspective. And I want to ask a question Again, it gets into finances, but that is what we're doing as well, which is that I've been very aware as I've done work in primary care in a medical school setting, that medical schools are the only institutions in the university structure that are dependent on a side business selling goods at a profit to fund their primary missions of teaching and research. Law schools don't do that. They don't have a law business. Nursing schools don't have a nursing business. Sociologists don't have a sociology business. I know, I'm married to one. Why do med schools do, I mean, I know why they did this. Hopkins was one of the first to do it, but what are the casualties of this system and how can we do better? What's a different way to fund what we do?
I mean, the casualties, I think, are just an accentuation of the casualties of the system, which is a lot becomes RVU driven, right? Because for those of you who don't work in an academic health system, the basic model is this: research loses money, education loses money, a lot of patient care loses money. So if we look at what Medicare, and in most states, Medicaid pays institutions or doctors' offices, we lose 10, 20 cents on the dollar, right? You can't make it up on volume. So it's not as if you're going to make a margin from those public paid patients. You're not going to make a margin on those that are on many of the exchanges. You're not going to make a margin on the uninsured or underinsured, right? So what do? In Maryland, you go negotiate with the one big payer, which is Blue Cross Care First, right? So they've got 60, 70% of the Maryland private market, and I have to negotiate a 200 to 250% of Medicare rate with Care First for that 30% of patients that are actually covered by Care First. So I take that revenue, I figure out how to subsidize all my cognitive care, which is all underpaid, right? So it's not just primary care, it's room, it's infectious disease, it's psychology and psychiatry. I've got to fund all that stuff with that little bit of margin. Then I've got to go figure out how to pay for educating medical students, residents, increasingly other health professionals, and anybody heard anything about NIH lately? So we put in about 52 cents on the dollar from a place like Hopkins. For every federal dollar of research we get, we put in 50 cents. Now, some of that is uncovered indirects, which they already want to cut more of today. Some of that is recruiting new faculty, bridge funding, trying to get young people trained in our programs so that they can become scientists and educators. So we're doing all of this in a really dumb way that does filter back to everybody else, but not explicitly. And it is not clear, but we all that are enrolled in Care First in Maryland essentially are paying for that research, but doing it in the most inefficient, oblique way possible. But this country has not decided that they want to fund public health, research, or education.
Okay. Atul, you get to ask Yalda the next question.
All right, so data. One of the challenges that we have when it comes to modeling out workforce stuff is I don't know what people are going to do eventually, right? So I'm a general internist. As soon as we realized, like, okay, we're not all going to be in closed model HMOs, we became hospitalists. That was a thing, right? We started that out in the West Coast in the late 90s. And so those people aren't really doing primary care. A lot of my PAs are going to work in ortho or GI, right? They're not doing primary care. So I can figure out how to measure, if I get better claims data, who's actually seeing the upper respiratory infection or the low back pain or the anxiety, and maybe I can model that out. But there is this other stuff that I'm going to call the special sauce of good primary care, right? That I know you deliver in your practice, right? But I don't know if it's like pornography. Like I know it when I see it, but I got to figure out how to measure it, right? So how do we measure that special sauce?
Yeah, it's a great question. We can't measure it right now. We don't have a way to measure it in claims data. We don't have a way to measure it in these large national surveys like the Medical Expenditure Panel Survey that we use to do our research on primary care. But if we changed our payment system and moved away from fee-for-service to a more value-based payment system, you could argue that we could measure it, right? Because that special sauce of primary care is really the stuff that's needed to meet the lower cost, higher quality, better clinician, and better patient satisfaction. And if we were on like a Medicare for all or some sort of value-based payment system and we had those claims, you could see that more primary care is lowering cost. More primary care is lowering, inefficient utilization of resources. We have some of that now. I think we would see more of it if we moved away from fee-for-service in the data.
Okay. And your turn.
Yeah, so as a pediatrician, and I know a lot of your research is also around prevention, and we know how important prevention is for kind of health growing older, but we also know that we just do not support prevention at all in this country financially. What policy levers or others can be pulled to increase our support for prevention and make a healthier America?
Yeah, and it's a wonderful question. Unfortunately, if I do my job really, really, really well, we won't see the costs at all. Mm-hmm. And pediatrics has a tough return on investment problem because the cost savings are so far into the future, they're not usually modeled in any cost structure system. Me doing a really good job with a baby, at best case, I start to save money in the kid's 30s or 40s or 50s. Nobody's modeling that far out. So one thing we could do is to model that far out. The other thing, though, that we could do is we could start looking at the other costs we save that aren't in healthcare, but are in other domains. And a man by the name of David Aylward has done some thought leadership in this place. And what he has suggested is we need to do a better job of capturing the increased costs in education, in the prison system, in social welfare, in employment, that there are other things that I do, if I do them really well, that save money for society down the line, and we need to start capturing those costs and pulling those policy levers.
Dynamic scoring for Dan's panel.
It's just the time horizon, actually, it sounds like. Okay. Well, those were great questions. I have to compliment the audience. Some of these questions are actually essays, and they're excellent essays. And I won't be able to get to all of them, but we're going to have a short break before panel 2. So please, we'll continue the conversation while everyone grabs a second cup of coffee. There are a couple of questions here that really relate to how care should be organized. Which we have only touched on. Thinking about how should primary care be delivered through small practices, through large practices? Should they be multidisciplinary? I won't call them multi-specialty practices that include different types of professionals. How would you organize this primary care? We'll call it institution of the future. We won't name it a practice necessarily. And maybe I'll start with you, Yalda.
I think it has to be individualized to the community. So if we're talking, for example, about organizing teams, what is the perfect team structure in a primary care office? Well, it depends. Are you in Washington, D.C., where there is pretty good access to specialists, or are you in rural Oklahoma? I mean, I think that really depends. And so, we all learned in our primary care residencies about doing a community needs assessment. I think we start with that. You have to do an assessment of what is needed in the community and build your primary care practice and team around community needs and community resources.
Great. Eliana, I might try a different question for you. There's a question relating to sort of non-clinical prescriptions, public health prescriptions, and how to bring them into primary care. Is this something that you're working on, and how would you see that being part of a primary care model in the future?
Yeah, no, that's a great question. Social determinants of health, big buzzword these days, a lot of debate as to how to address this or not in the clinical setting. When I was at Duke University, we had a clinic that provided diapers, cribs, coats. It was like everything except give people money. It really was. It was what I called workarounds to poverty. And we have, I think, a better system at Hopkins where we do a lot of screening and then have people who are actually Hopkins students work with families and work on a case structure where they meet with that family again and again over time and provide them with the needs that they have. Again, beautifully done, but another workaround to poverty. And I'm a believer that we should have social structures that allow people to have those needs met outside of the doctor's office, outside of the clinician's office. That being said, it's certainly a beautiful thing that I can help families in this way. And to whatever extent it builds trust or allows the families to come back for their routine well child care, that's an advantage too. So I have mixed feelings about it. Obviously want these families to get the services, not sure this is the best way to do it. I had a research mentee who did what she called a landscape analysis, where she literally surveyed all university clinics and asked them what they're giving away in the, everything from books to diapers to toothbrushes to thermometers to, winter coats to underwear to menstrual pads to condoms. The giveaways are incredible, but they're incredibly varied. There's no actual, and not always responsive to community need, and not always given out related to screening. So everybody's doing it in a different way. It's very capricious, it's not very systematized, and therefore it's probably not the best holistic way to do it.
But I want to go to something you started the panel with, which was these are failures of social policy, right? And we've expected the health system to go in and fill in the blanks on all of these failures. The other great thing about the OECD comparisons is that all of those countries look very different when it comes to investment in social welfare. Poverty reduction, pre-K through 16 education, right? Wealth transfers. We have 20% of people, including children, living in poverty. That doesn't get anywhere near 10% in those other countries. We allow the very wealthy and the very poor to exist at the same time, which means when you look at averages, we look like everybody, but it's not the same. The outliers are incredibly different, and we do not have the political will at this point to fix social policy. Maybe someday, I'm not so optimistic.
All right, so for the time being, a more systematized way to have these social needs that affect health directly, triage, or I shouldn't use the word triage, but in a systematic way allocated to the families most in need would be part of a system that a good primary care system could rely on being there. There's another question here about, if we do have the right number of people in the primary care field now, are we concerned about the future, and in particular about the international medical graduates? I'm looking at you for that one, Atul.
So historically, about 1/4 of all of our physicians practicing in this country are foreign born. Not necessarily been a bad thing. We get to choose the best and brightest, and in fact, sometimes the most culturally agile physicians to come in, whether I'm working with a large Somali population or Spanish people, it gives us a greater ability to take the best from the world. Not so great for the world, we try and limit the brain drain, but I do think the challenge has been we haven't been able to expand residency positions fast enough, even though we've grown medical school enrollment. The DOs have grown by 200% over the last 20 years. MDs have grown by about 15 to 30%. And we just need more GME slots, and I think we need to accommodate all those international graduates coming in as well, who offer us something in terms of excellence.
Okay, great. So to wrap up this panel, I just want to pose what I think I've heard as the vision for primary care, and then I want to allow each of you to amend what I say, because we've got to set this agenda for panel 2 to solve all these problems. So what we want in the future is a primary care system in which people can form a relationship with a trusted provider if they're at the stage of life where that's something they seek and it would benefit them, where a team that meets people where they are in their communities or schools or things like that helps to support the primary care clinicians, where AI is trusted and used to reduce burnout and to make all the professionals in the system more effective, and where we have a sufficient number of professionals going forward to meet the needs of the population. What have I forgotten? Let's start with you at the end.
I'll amend just the first part of that. I think it needs to be good primary care for every single person from newborn until death. So not dependent on life stage. And I think we also need to change our payment system to support all of that.
I would just add perhaps that physicians do need to lead, and they should be, instead of saying, hell no, nobody can do what I do, to say, what is appropriate for others to do with the right experience and training. The second thing we haven't talked about, but I'm going to have Dan fix this, is we have authorized money for infrastructure. We should be laying the last mile of fiber broadband in every community in this country, and then at least getting them a micro hospital, an EMT, an RN, an NP, a PA, a doc, whoever, locally.
I think spending money on primary care is something that needs to be doubly, triply emphasized. I think that money should go towards time.
Yeah.
What everybody wants with their primary care provider is time.
Yeah.
You leave the visit saying, it was so short, I didn't get a chance to ask my questions, they don't really know me. Or you say, boy, that was amazing. She is so good. She spent so much time with me. I hear this from my parents, I hear this from my friends. It's all about time. So if we could put that effort towards the actual respect for time and not draining our time with ridiculous, bureaucratic, messy things, and we could spend that time with our patients, I think we'd see a revised system, and I think we'd see a healthier public.
Great. All right. Please join me in thanking this panel for setting up a hard agenda for panel 2.